911 emergency. Pursuit accident.
Nothing is ever written in stone. Darling, oh, I am coming home.
Good afternoon, everyone, and welcome to Madrid. And I'm about to open this, I'm opening this, and it's very difficult to tell you all the feelings that I have. Because as a president of the European Society of Intensive Care Medicine, this is the first time that we are having a face-to-face meeting together. And it's a special occasion. We call these Lives 40 because it's 40 years now that the society was born. We are not going to celebrate just here, but it's a start of what we hope is going to be a year of celebrations. Before we move on with the program, let me also thank you all, the office, the executive committee, the leadership, the council that we just met, but all of you here today and our members, because we will talk about this later. But the society really stick together, and the membership stick together during the last 2 years and a half. and it allows us to do a lot of activities that we will show you, we'll share with you, but also it allows us to be again here together, because together we are intensive care. As a gift for everyone in the society, I'm also very happy to tell you that today we are releasing a web app with the support of MSD. We've been working for a year and a half with lots of experts from the society. It's an antimicrobial stewardship application, but it's going to be very different from anything that you've seen before. The philosophy behind was to try to give a practical tool to manage an infection at 3 o'clock at night when you're alone in the intensive care. You will be able to access as a member from now basically this, and give us your feedback. I'm sure there will be things maybe to improve, but I'm sure it will be very useful. And I really would like also to show you this picture just to show the amount of people on top of all the office of the society that have been working to put this together. It's been a huge effort. In particular, I would like to thank my friend Ian De Valle, because we've been working relentlessly, and he's done a fantastic work to put all this content together over the last year and a half. It's also another important day today, not just because we start this year of getting together and celebrating our community together again, also because, as you know, or as you will know now, the 12th of May is the International Nurses Day. And I know that I speak for everyone here, saying that our nurses really are the core of our clinical care at the bedside. Intensive care is about the team. What we've tried to tell institutions for the last 2 years and a half is that a ventilator is not an ICU bed. An ICU bed is a group of competent people working together as a team, and our nurses are fantastic, together with all the other members, but really I would like really to thank them and to applaud them for everything that they do. So today we start a year of celebration together. It's not just here. I remind you, we will celebrate also in Paris and in all of the other activities that we are doing together with the society. But tonight there is a party, so please join the party, starting at the poster session. And also with a lot of emotions about being here now, before I give the word to my friend and Congress Chair, Jean-Louis Teboul, there is also another very important moment. The society every year awards honorary membership to very special people, very important people for our community. And I would like to invite on stage also Jean-Louis Teboul and my friend and president-elect of the society, Ali Azoulay, because we are about we're about to award a honorary membership, a special honorary membership to one of our foremost members of our community, who is here with us, Jordi Mancebo.
As many as we want.
Okay. And Jordi, I know you want to say something.
So, thanks so much. I think that I've lost some kilos since this picture that you see here. You know, I'm very proud of receiving this distinguished award, and I feel a profound sense of joy. And I only wish to thank you first, the society, its executive committee, and its whole constituency for this distinguished award. Second, I wish to thank the patients that always have driven my clinical and research career, which, by the way, I've had a lot of fun pursuing this. I also wish to thank all the friends that I've met during this unbelievable voyage, some of whom have traveled many, many miles to be here. So thank you very much. And who is people that I love a lot, and with whom I've had again many, many hours of fun. And last but not least, I wish to thank my son, my daughter, my family members, and I apologize for taking out of them so many time. But thanks again, and enjoy the meeting.
So, without the work of the Congress Committee and the Congress Chair, we wouldn't be here today. And you will see that actually it's going to be a lot of fun, and I leave the word to my friend Jean-Louis Teboul to present you the Congress. Jean-Louis.
Thank you. Well, thank you very much, Mauricio. So I'm very happy to be here and to see you face to face. You know that this is the first face-to-face meeting of the SICM for almost 2 years, I would say. And it is important that it is taking place in Madrid because, as you will remember, we should organize the annual Lives 2020 in Madrid. But as you know, due to the pandemic, it was cancelled, so it was symbolically important to organize this event in Madrid. So to go to the point of this Congress, yes. So this is a worldwide conference. Almost 40 countries are represented in this room. 73 speakers, 700 or maybe more, I hope, delegates. And the program is very rich, as you will see, because the slides are very slow to appear on the screen. Many sessions during these 3 days, you will see. And in fact, the program is subdivided in 2 parts in parallel. Educational part, as you know, we have a lot of workshops running right now, or this morning or tomorrow. You will see we have 5 workshops. This morning already, we had the renal replacement therapy workshop, the airway management workshop, also the ECMO workshop, and this afternoon the mechanical ventilation workshop, and tomorrow again mechanical ventilation and also hemodynamic monitoring workshop. And these workshops are very well attended, almost or maybe more than 200 delegates participate in these workshops, and around 30 experts, 30 speakers. We also have the case-based fundamentals, so clinical case-based discussion, you will see, in English, but also in Spanish. 2 different sessions, of course. Also, the breakfast meet the experts tomorrow morning and Saturday morning about end of life in the ICU for one, and sepsis the other one. And we have also the so-called scientific program, which is very rich and which combines, how to say, 20-minute, traditional 20-minute lectures from speakers, and also in parallel some interactive roundtable debates. And we want to have some interaction between the speakers, the moderators, of course, and the attendees. This is the objective of this meeting, is to interact with people, because, you know, we had a lot of online conferences during these last 2 years, and we want to have something very different, something with interaction. We also have some poster sessions or abstract sessions, a majority of poster presentations, but also 5 oral presentations. We selected 180 presentations. And we also have two industry symposia at lunchtime, organized by GE Healthcare and Inotrem. And interestingly, if you miss something, because, for example, you are in this main room for listening thematic sessions, and in parallel, you have some roundtables. You can watch afterwards these roundtables, or the opposite. You cannot watch the workshops, but you can see everything afterwards on the website, and it is possible to watch all the thematic sessions whenever you want, after the Congress if you want. Interactive debates, interviews, because I will say some more about this in a few moments, abstracts, and industry-sponsored sessions. These are our sponsors for the Congress, for the conference, and our sponsors for the workshops. I would like also to say something about the staff, the ESICM office members, and a lot of thanks to Joël Alexandre and his fantastic team, because this is my first year as chair of the Congress Committee, and I see all the work which is done by this fantastic team for this Congress, but also for other tasks. And I would like to give a special thank to Cindy Martinez, to Melania, to Elise, to Anita, and others who all participate in this Live 40. Thank you very much for your attention. And after this talk, okay, we can start our conference with a thematic session, and don't forget what Maurizio Cecconi told you about the cocktail at the end of the sessions at the same time as the first poster session, okay? So I will now I would like to see Joseph and Susana Lobo from Brazil, and she will moderate this session with Joseph Kisisioglu, the past president of the SICM, and I'll let you now to present our first speaker.
Is it okay? Good afternoon, everybody. My name is Susana Lobo. I am from Brazil. I was the president of the Brazilian Society in 2020 and 2021. And when we had the worst scenarios of COVID in Brazil, I am a professor in a city in São Paulo, and it's a great honor to be here. And I really appreciate the invitation. I'd like to congratulate the Society for this big celebration, 40 years, and congratulate everybody, every former president, delegates, committees, and all the people that was responsible for the success of this huge society.
Thank you. I'm Joseph Kisisioglu, and I work in Utrecht, the Netherlands. And it's an honor and privilege to be here with you, chairing this session. And that's why I would like immediately to invite my dear friend, Maurizio Cecconi. I just wanted to present him, especially because it's easy to present him. He's known as our president from Milan, Italy, and he will be giving a talk on leadership during the pandemic.
Sí, sí, sí. Hola, hola. Sí, 1, 2, 1, 2, ok. Sí. All good? Yes? Perfect. Hola, hola.
Non, mais c'est pas allô, il faut qu'on fasse le test là, c'est ce qui va partir dans le live. C'est bon. De momento estamos oyéndote en el streaming.
1, 2. One, two, 1, 2, 1, 2. One, two, 1, 2, 1, 2.
No, it's not.
You are fantastic, Joel. He's great. How long is it? Nothing to touch you.
Jean-Louis Tegout, you can say Jean-Louis Tegout is my name. So, I have a camera. Yeah, but I have a camera for me.
So I speak to you. You make the shot, but we speak to each other. Okay, now I understand. Are you going to give us feedback?
Hello everyone, I am Jean-Louis Tegout from Paris, France. I am very happy to moderate this session, this live TV session. We are in Madrid for the Lives 40, which is an event organized by the ESICM, European Society of Intensive Medicine. And this is the first session we have to present today on the TV. And this is dedicated to interviews of some speakers. And we have today two speakers. I will introduce you. First is Professor Sheila Malhotra from Mumbai, India. She's the president-elect of the Indian Society of Critical Care Medicine. Thank you very much, Sheila, to be here with us. And we have Professor Maurizio Cicconi from Italy, Milan, who is the president of the ESICM. And they already gave talks during our Lives 40. And I would like to ask them to summarize a little bit their talk or their presentations. And also I will try to ask questions. And if you have questions, please send us the questions, and I can also ask this question for you. So thank you, Sheila. Thank you, Maurizio. Maybe I will start by you, Maurizio, because you are the president of our society. Can you tell us about this event, the Lives 40? what is this event? What do you expect from this conference?
Hi, Jean-Louis, and hi, Sheila, and thanks for letting me go first for the honor. I'm very excited, first of all, to be here, because this is the first face-to-face event since the beginning of the pandemic in early 2020. And it means a lot for me, but I know it means a lot for you, because you've been working on organizing this Congress. And I have to say, it's fantastic to be back with our members, with our community, face-to-face. Maybe you can also share some numbers of this, which I think is a success, and in terms of delegates, faculty, and so on. But let me just start by saying that. And in order to answer your question on what this is, this is slide 40. Why did we call it 40? Because in these months, 40 years ago, that was the birth of our society. And so we said that 2022 is going to be a year of celebration for ESIC, a year to celebrate together. And we're starting to celebrate here in Madrid, but we will carry on for the next 12 months.
But this meeting will not replace the Lives 2022, which normally will take in Paris in October.
Correct. So this is an extra meeting that we have indeed.
Okay, thank you very much. I will ask you some questions about your talk, your presentation, because you talk about the leadership during the pandemic. And can you summarize your message to the audience?
Yeah, it was a very important talk for me, because it was a moment of reflection and to tell the story, I think, of our community. Leadership is not just about mine or your leadership. I think it was the leadership of our society, of our community during the last 2 years and a half. I think, we have shown the world the importance of intensive care units, of intensive care teams. And, before the pandemic, not a lot of people understood what we do in intensive care, what our job is. And this crisis has really shown to the world the importance of our teams for the safety of patients, for saving patients, for being there during the most difficult times of patients and their families. And the message that I've given is what I've learned in this pandemic, which is, if you don't work in an ICU, looking from the outside, maybe you think that what you need is ventilators, beds, monitors. But that's a very little part of what we do. One key message that I was trying to give, helping the European institutions getting ready from the first wave to the next wave, was that a ventilator is not an ICU bed. An ICU bed is a group of competent people working together as a team. That was a key message of my talk. Another thing which was not a message, but I think something that I'm very proud of our society, is that I think we reacted very fast, not just for us, but for the rest of the world. If you remember when the outbreak started in Lombardy, where I used to, where I work, and when we were starting to do the first webinars, we've been very fast, I think, as a society to disseminate knowledge, but we didn't restrict that to our members only. So in a way, I think our members have supported us in the last 2 years by sticking with us and allowing us to be basically a leading light for knowledge, for sharing with the rest of the world. And we've done this for the pandemic, but also recently with other crises like the conflict in Ukraine, the refugee crisis, and so on.
And I heard that you talk about the C19 space. What is exactly?
So C19 SPACE is an acronym that stands for COVID-19 Skill Preparation Course. And I have to say that's been a fantastic project that we did as a society. The story behind is that when we were giving information to the European Commission on how to get ready for a second wave, they were telling us that they were thinking of buying ventilators and drugs and devices to be distributed in case of another surge. And we said, that's fantastic. That's important. But the reality is that the biggest problem that you have during a surge is that you need competent people able to operate 2 surge ICU beds. So we said, what's really missing is a training program aimed at healthcare workers not working regularly in intensive care that could be used by ICU teams to train other people. So that was the idea, that was the background. We got basically the commission telling us, okay, we want you to organize this for Europe. And the aim was to train 10,000 people. Actually, in 3 weeks, we put together 70 experts. We built more than 24 hours of training material in different languages, a track for physicians, one for nurses, and at the end, we trained more than 17,000 healthcare workers just in a few months. And now we are collaborating also with the WHO, and we are opening this also to other parts of the world.
May I ask you some questions about the pandemic? Sorry, after we'll speak about airway management. India also faced a terrible crisis during this pandemic. And how did you react? How did the Indian Society of Critical Care Medicine react? And probably there was some interaction also with the SICM.
Right. Thank you very much for this question. So each wave of the pandemic was a unique challenge for us. So in the beginning, we were fortunate because we had a very strict lockdown. We had limited resources. The society was working with other organizations to ramp up the supplies because, as you know, India is a very big country and we're very largely populated, so we were very worried about the spread of the virus. And we were learning from the experiences of the European countries. We were learning from SICM, the way you handle the pandemic. So we had 2 months. The pandemic really started, and the surge started in the middle of May for India. So we had time to prepare and ramp up our resources. So in the first wave, we were reasonably okay with handling the pandemic, and the society was largely involved with training and also helping various ICU and non-ICU clinicians to quickly work in ICUs and form teams, etc., and also mobilizing resources along with the government and other organizations. But in the second wave, we started becoming very complacent. That was when we had the Delta wave, and that was the time when we had a huge crisis with oxygen.
Yeah.
And all along we were thinking, we don't have ventilators, and we were trying to get more ventilators and manpower, but what we really faced was a problem with oxygen. All along, we never thought that we would run out of oxygen, because in a single day, we had 10 times more the requirement of oxygen, and it was more a problem of supply and demand, and most of the oxygen plants are outside the cities. Transporting big tankers could not be done fast, and it was a huge crisis that we faced. So each wave taught us different lessons, and I think the very important lesson that we have learned is not to be complacent, and you can have new challenges, and you should work together with other specialities, something we didn't do in the beginning, to be better prepared, and to, also with government organizations and cross-specialities, we should cross-talk and learn to work together so that we can be better prepared for any other crisis, not just a pandemic.
And how did you receive help from your government? In my country, for example, of course, at the beginning, for the first wave and also for the second wave, we had a lot of facilities in the hospital. We can ask everything we want. And now I have the impression that things came back to the past, and now it is again difficult. So if we have to face a new wave, it will be very difficult in my country to face because we many I would say personals, maybe nurses left, for example. They change the job. They went to they change their activity from public to liberal activity, etc., etc. I think it would be very difficult now to redo the story. So what is your...
So a very important lesson that we learned, seeing the best healthcare systems in the world collapsed during COVID. And it really taught us that, of course, the intensivist is at the forefront and we can help. However, once the patients start to come to the hospital and fill up the ICUs, no matter how many beds you have, how many ventilators, how many skilled manpower, it will never be enough. So this has to be controlled in the community. And that is where the government and the public health measures really make a difference. So we have to work together to do this, not in isolation. And one of the things we really neglected, because we were so much into the patient care and trying to make things better, was we didn't look into burnout. And we started realizing through the pandemic, especially like you say about nurses, that there was significant burnout. And healthcare workers are one of the most precious resources of any healthcare system. So it's very important that we look after them And this is something that we've started to recognize, not just with nurses, but even doctors and other people, that we should address the burnout issue and make sure we are better prepared in future for the pandemic with this.
And for Europe, Maurizio?
No, I think I can relate a lot to what Sheila was saying, but also to your message. We've definitely seen that, the first wave somehow was the most surprising one, but the easiest in terms of collaboration, resources. Everyone was trying to help us. And I think we also failed a little bit with the narrative, with the public, to tell really the impact of this crisis. Because every time you were filling beds with COVID patients, some elective activities, some other activities have to be stopped, and then you have to try to get them back when the surge goes. So it's not true that our teams have worked hard only during the COVID surges. We've been working hard for the last 2 years, and not just us, the rest of the hospital. I am not sure we've been very good in taking care of, making sure that the work-life balance in such a long period, because this is not just a few months, it's 2 years and a half now, especially for some of our team members, nurses. We've seen the same. Many nurses have left. We have to do better, I think, even as a community, to recognize, to speak up, to make awareness about this problem, and to try to be, I don't like the word resilient, but when I mean resilience is that we need to be more resilient, probably exactly to be able to look after carers, to look after doctors and nurses as well, not just the patients. Otherwise, our systems will collapse in the future.
And what about vaccination of doctors and nurses in your country, Sheila? At the beginning, we had some people had some reluctance to be vaccinated. I don't speak about the general population. I speak about doctors, nurses in the hospitals, for example. And finally, we managed to convince them to be vaccinated. But at the beginning, it was some people were reluctant. In India too?
Well, this proportion in India, interestingly, was very low. In India, seeing the population, just getting everyone vaccinated was such a challenge. So people were feeling very happy to just get the vaccine. They were trying to get the vaccine. So the hesitancy was, very less compared to the rest of the world. I can say that, yeah.
Italy was very interesting. We were so affected by the first wave, especially, in some parts of Italy, that I think healthcare workers really realized the impact. So there was very little hesitancy. But on top of that, there were also governmental rules about the fact that you could not work in the hospital without being vaccinated. And of course, that caused some issues with some people, but they were a minority. And I have to say, the majority of us, they were happy that there was this mandatory rule about vaccinations, because especially with the first variants, the data was also showing that your risk of getting infected was much lower, and therefore it was lower the risk to infect your patients. Maybe now it's a little bit different, but I'm still very much in favor of vaccinations for us.
Professor Jean-Louis Vincent from Belgium is joining us now.
Sorry, I was busy
I know,
at the
no
session.
No
Yeah.
problem. And so we talk about the pandemic.
I'm sure that's a
You
topic.
understood, of course. And so I would like to move to the second topic of our session right now, about airway management. In fact, this morning we had a very nice workshop about airway management in the ICU, and Sheila Mayotra was one of the directors with Samir Jaber. Can you summarize what was this workshop this morning?
Right. Thank you very much. So it was, firstly, a great honor and pleasure for me to come from Mumbai to Madrid and work with a real diverse group of attendees from across the globe. And I'm really grateful to ESICM for giving me the opportunity. So airway management is something that is taken, in ICU, is something that is taken very lightly. People just look at it as getting the tube inside. And even anesthesiologists who work in the operating room think airway management in the operating ICU is just an extension of airway management in the operating room. And actually, all along when we are taught about airway management, we are taught about how to oxygenate the patient, get the tube in. We are taught about the technical skills, about anatomically difficult airway. But critically ill patients have what we call a physiologically difficult airway. So because of the critical illness, the hypotension,
So what
the
are the main
metabolic,
differences between the ORs, the operating room, and ICUs in
Right,
terms
so-
of intubation or airway management?
Right. So first of all, airway management in the intensive care unit is a very high-risk procedure. The complications with airway management in ICU are much higher than in the operating room. And in my mind, the reason for this is, I think there are three fundamental differences. So first is the ICU environment. It is a very complex environment. Unlike the operating room, just getting to the head end of the patient is such a struggle. There's so much clutter around. You don't have, a very, all the tools that you have in your armamentarium that you would have in the operating room. So the environment itself makes it very complex and increases the risk of complications. Number two is the skill of the operator. In the operating room, we have very experienced anesthesiologists and we have readily available help. Whereas in the ICU, you may have anesthesiologists, physicians, internists, pulmonologists with varying level of skill. And the skill of the operator is one of the most important thing to ensure, safe and effective airway management. And the third most important is the patient itself. We don't have the stable, optimized, fasted patient who comes for surgery. This is a critically ill patient. So I have a physiologically difficult airway. And in addition to this, if you also have an anatomically difficult airway, then it makes airway management very challenging. So these three conditions make tracheal intubation in ICU a very high-risk procedure.
Yeah.
And what we try to emphasize today is that you should consider every intubation in ICU as a high-risk procedure.
Yeah. Thank you.
Well,
Please.
perhaps in conjunction with what you said, I found interesting to see that in the U.S., in New York in particular, when they were so overwhelmed by the crisis, they worked by teams, and the anesthesiologists were invited to intubate the trachea of the patients in the intensive care unit. Of course, intensivists can intubate the trachea, but they have to do some other things as well. And so they could do other things whilst the anesthesiologist, who doesn't know much about prolonged mechanical ventilation, the RDS, ECMO, etc., they could actually do it very well. And so the same thing for inserting the lines. You could call for an IV team who will insert the line. So our nurses can do something else and can watch over the respirator and the ECMO, etc. And so having specialized people in the ICU may be a relatively good idea. We have not done it in Europe really, but the concept is good for a crisis management. Speaking about crisis.
And I think also that what's different in the ICU is that, I work both in anesthesia and intensive care. It also surprised me that in the anesthesia, you have everything, as you said, perfectly organized. And actually in the ICU, sometimes when you have the sickest patient, you don't have the same standards, let's call it like that, ready for the intubation. Not everywhere, but some studies that have been published, they show that, for instance, Untitled CO2 was not always used, which I think is something just that we should not accept. So there is also a little bit of cultural work that I think we have to do, and I think we are doing more and more of this now.
And Sheila, sometimes still there are some difficult intubations, for example. And what are your recommendations to improve this?
Right. So first, I'll just allude to a paper we recently published in JAMA, which was published in March 2021. For the first time, we looked at global practices of intubation, tracheal intubation in ICU. So it was a study of 29 countries and close to 300 tracheal intubations. And it actually showed that the risk of the complications were 45%. Almost 1 in 2 patients who undergoes a tracheal intubation in ICU has a complication. And interestingly, one would imagine that hypoxia would be the most common complication, but it was not hypoxia. It was hypotension. 42% of the patients had hypotension.
Hypotension is very important.
Followed by hypoxia, and other complications. And this was quite an eye-opener because we are always worried about desaturation during tracheal intubation, not being able to intubate. So this is why a big emphasis now on strategies to improve, decrease the complications and improve first-pass success. So of course, coming to hypoxia, the peri-intubation oxygenation strategies. So earlier we would just talk about pre-oxygenation. Now we have more advanced ways to pre-oxygenate, which not only give you oxygen, but give you some level of PEEP, like we have high-flow nasal cannula oxygen, NIV, etc., for these high-risk patients, and peri-intubation oxygenation. So you continue nasal oxygenation during attempts at intubation. So we've become quite good at this, not just plain pre-oxygenation, but big focus on preventing hypotension. This is very important. So all along, we used to give fluid bolus to...
What could be the reasons
So
for hypotension?
Yes, so this is very interesting because as an anesthesiologist in the operating room, we don't think of hypotension. So one of the very important things, critically ill patient coming very tachypneic, there's tachycardia, hypertension, big sympathetic drive, and you have a false sense of security when you see such a patient. And the moment you anesthetize them and you lose this sympathetic drive, there is precipitous fall in blood pressure. They are already maybe in shock, maybe hypotensive, intravascularly depleted, and this is accentuated in these patients. They may already start with hypotension. In addition, after you intubate these patients, with the positive pressure ventilation, there is decrease in the venous return. And the most important factor is the drugs that we give for intubation. So drugs like propofol, which are commonly used in the operating room, can cause precipitous fall in blood pressure, lead to hypotension, cardiac arrest. So guidelines recommend the use of ketamine or etomidate, unless contraindicated because they are relatively cardiostable drugs for intubation. And just yesterday in the Blue Journal, we published a subgroup of the Intube study which showed that propofol is an independent risk factor for development of hypotension in the critically ill patients. And it was interesting to see that in the Intube study, 40% of the people still intubating patients in the ICU are using propofol. It seems to be the most popular drug in the intensive care unit. So definitely we have to focus on our practices. And like Professor Cecconi said, capnography is very important. Even a single esophageal intubation can result in more than 50% of hypoxia. So we have to be sure that the tube is in the trachea. And capnography in the National Audit Project 10 years back was identified as not using it causes high risk of neurological complications and mortality. And even 10 years today, after the NAP4 project, only 1 in 4 people are using capnography to confirm tracheal intubation in ICU. So this is an area we have to really work on in the intensive.
What about the other measures? I mean, you were talking about fluid.
Yes.
Do you use fluid? Do you use vasopressors? Do you
So
can
this is
anticipate
really
profound
interesting.
hypotension?
So all along, so we have the intubation bundle from Professor Jabert, which talks about preloading with 500 mils of saline before intubation because you are anticipating hypotension. But recently, the randomized control trial from the Vanderbilt group showed they'd use fluid versus usual care, and they showed no difference in cardiovascular collapse following tracheal intubation. So if fluids doesn't work, perhaps there is a role of using vasopressors early, prophylactically, empirically in these patients, because hypotension is real. Fluids don't seem to make a difference. In the Intube study, though it was observational, the mortality was higher in patients who receive fluid. So perhaps you can start a low dose of vasopressors.
In every patient, or you have to personalize?
I think one would start with an infusion and, of course, individualize depending upon how we go along. And now we are doing a randomized controlled trial in our unit comparing fluid bolus versus a low dose of vasopressors and looking at the incidence of cardiovascular collapse following tracheal intubation.
Thank you very much for these recommendations. So we talk about personalized medicine.
Yeah, I'm not so sure that the hypotension following the endotracheal intubation, which usually reflects some degree of hypovolemia, I'm not so sure it's so bad because usually it's without sequela. And if you measure the lactate levels after these episodes, that can be sometimes a bit prolonged. The lactate levels remain normal. So it seems that the tissues do not suffer very much from it. So I would not be too focused on this. I'm not so sure that we need to prepare a noradrenaline solution in each case. If we suspect that some hypovolemia may be present, it still makes sense to give some fluids before endotracheal intubation, provided that we have the time to do so.
So let's go, yeah.
If I can just say, I agree, but also it's important to say that every situation is different, and what you want to prevent is not just the little bit of hypotension, but the patient where you can have the catastrophic, hypotension with RS, which is very rare. But for that, every patient is different. I also think that it's very difficult to tell you're going to use this recipe all the time.
I agree
But
with...
it is due to the increase in intrathoracic pressure. So physiologically, if you return to the ABC of physiology, it's because venous return is falling and therefore cardiac output. So the best thing to do is to give fluids at that time. Sometimes you may have to give a vasopressor transiently if it's really severe. But
That's very important, the vasopressor, for the time, because the fluids may take a bit of time to work, and the vasopressor is the fastest thing.
Vasodilatation. I agree with Professor Vaso about the long-term effects and the lactates, but it's the immediate life-threatening complications. You can have profound hypotension, arrhythmias, cardiac arrest is almost 3% following tracheal intubation, which is very high, often secondary to hypotension.
So now, thank you very much, Sheila. Now let's go to the presentation of Jean-Louis Vincent. You gave, I would say, provocative, maybe, talk about personalized medicine.
why is it provocative now? It's basic medicine. It's not provocative to return to basic
You know
medicine.
that I share your opinion about this, but can you tell us more about your presentation? Can you summarize what you wanted to say?
Well, in one sentence, the summary is that we must still be doctors. And it seems some people sometimes forget about it, and they want to start from scratch. And they want to do studies on anything. Again, the type of fluids is the best example. People don't want to hear what hyperchloremia could do to you. They just want to see a very large prospective randomized control trial showing that when there is significant hyperchloremia, there is harm. There is more renal dysfunction. So I have even ethical questions about it, but I return to that at other sessions. So, we cannot give a given blood pressure level applicable for every patient. We cannot give a given cardiac output level for any given patient, etc. That's true for everything. So we need to see what's better for the patient and if the patient can benefit or not from any intervention. Should I give more fluids? Maybe benefit, maybe harm. Why don't we evaluate the benefit versus harm ratio, etc. Vasopressors, we could increase them more, but isn't it better to give more fluids rather than to increase the vasopressors, or vice versa? Isn't it better to increase the rate of vasopressors rather than fluid? So we need to individualize this, return to the patient, re-examine the patient, and avoid staying away and being on the phone. Yeah, give another 500 cc's of Rangers lactate, and we will see. We will see what? Well, we will see how the patient is. Yeah, but how? What will you look at? And then the nurse is left alone. It's okay, I have to give 500 cc's of Rangers lactate, but I'm not sure I know exactly what I will do.
Yes, Jean-Louis, what do you think about guidelines? Because this is a little bit sometimes in contradictions with individualization, personalization. What do you think about guidelines?
Well, you know what, but that's something that we can speak now in a small committee, but the guidelines that we proposed a number of years ago, just maintaining the central venous pressure between 5 and 18 or something like that, the exact numbers do not matter, it was not so bad, because when you arrive in the ICU and when you see that late in the night the patient received little fluid, but still has a central venous pressure of 3, I'm sorry, but there is plenty of space for more fluid. If the patient has a high CVP, you may question, is it right ventricular dysfunction? Does the patient have pulmonary hypertension? But any doctor knows that or should know that. So these simple rules for the doctor on call who is not an expert in sepsis, after all, were not bad, or at least not worse than suggesting to give 2 liters of fluids in 3 hours. 3 hours, you know how long it is? 2 liters of fluid in 3 hours for any patient with sepsis. To me, that does not make sense at all.
Yeah, I think it's important, however, not to pass the message, that the big trials are not teaching us something. Because, you mentioned, for instance, the type of fluids. Recently we had these large trials about balanced solutions and saline. And I have to say, my take-home message from those big trials is actually that if you look at normal saline, it doesn't seem to be as bad as maybe we were thinking. My preference is still for balanced crystalloids normally. But I would argue, that actually what you take out of some large trials sometimes, that we understand a bit maybe the damage, the harm signal, or sometimes even the safety signal of something where we may have a dogma, we have a belief on that. So
but
to
that's
me,
dangerous, my good friend. What you are saying is dangerous because
Why?
it's the wrong interpretation of these trials, the wrong interpretation. Because some people now, and I had a debate about this at another meeting, some people say, oh, there is no big difference between the two. Saline is cheaper than balanced solutions. So let's give saline to everybody. That's the bad.
no, but that's not what I said. No, that's not what I said. Well, it's not a huge difference.
When the chloride levels go to 110, like in the Vanderbilt studies, you can see that there is more renal failure. Now, people look at the study either from Brazil, where they found no difference, but they didn't give any fluid. So, of course, there is no difference. If you give 1 liter of fluid and nothing else, you cannot see any difference. Or the study from Australia with thousands of patients, no difference. But they also gave very little amount of fluid.
Yeah, but,
and the chloride levels reached
but
one.
Yeah, but what I'm saying, which is what I said, was that overall, if you see, the effect is probably not as big as people were thinking. So yes, I have a preference for balanced crystalloids because they make sense physiologically, and it makes sense to have a strong ion difference.
Along the same lines, you could say that measuring blood pressure doesn't help because
Yes,
there is no difference in outcome whether you aim at one given or another level of blood pressure.
Yes, but we have moved from interpretation of RCTs, from guidelines to interpretation of RCTs, which is a little bit different. Of course, when we interpret RCTs with no difference, it means that some people can benefit sometimes.
Yeah.
And
Exactly.
some people can suffer from, yeah. And sometimes there is no difference. It depends. Those are 3 possibilities. But, okay.
But there is important information also when there is no difference. We should not throw away those studies.
Yeah.
That's an important
But
message.
also sometimes, for example, if you have a better treatment for some patients and a better treatment for some other patients, you have no difference if you mix. But again, it means that you have to individualize, finally. This is a link between RCT's results and the strategy. So again, protocolized, maybe could be related to guidelines versus personalization. What do you do in your practice, Sheila, for example?
So I have a different take on it. I would take the median path. I wouldn't say guidelines are useless because when you are an expert, you could, these guidelines are written usually by experts, and you could deviate. You can justify why you deviate. It's not that the guidelines are gospel truth, but when I have a trainee in the ICU at 2 a.m. in the morning, they need some guidance. They need to know. So it's a good pathway to follow for some basic, kind of management of the patient. You can't just say individualized care for every patient. Well, that would be difficult for somebody to do who is just coming to the unit.
What do the guidelines tell you when you are at 3 o'clock in the morning? You read them carefully.
Right.
What will you do? That's the point.
Right.
When it's based on good trials. There is
Right.
no recommendation you can make. So there is no recommendation about blood pressure, no recommendation about fluid administration.
Right.
They just say you need to give antibiotics. Of course we need to give antibiotics.
Right.
So that's the problem. I'm very much in favor of guidelines. I started the guidelines on sepsis in Brussels in
Right.
2000.
So
So I think we need guidelines, but the problem is that as they are now, just based on trials, prospective randomized control trials, and nothing else, it doesn't help. We need congresses like this. Why do people come to these congresses? They can read the guidelines
To
at
discuss,
home,
yeah, to
but they want to know what
But
we
Jean-Louis, you brought massive,
why you are here.
massive contributions with physiological studies, but also with some trials. If we don't
We need
proceed,
trials. I'm speaking about the large trials. Again, I'm
so how do we build the evidence?
investigating the effects of intervention on mortality in heterogeneous patient populations. In COVID, we have shown that some strategies can change outcome. And that's so good. That's great. But a blood pressure like this versus a blood pressure like that, a little bit more chloride or a little less chloride, that
Even in,
brings
even
any
in COVID,
difference.
even in COVID-19, some treatments show some benefits. For example, dexamethasone, but you know the difference is not so big.
I agree.
And finally, everyone receives dexamethasone
yeah.
because the difference was in favor of
But if
dexamethasone.
you remember, the trial was also very important because we saw if you need oxygen, you're sick, there is a signal that improves. If you're not on oxygen, it can actually harm, you know? And I think that's where we are learning that in the future, maybe we need to do large trials, but where we are even able to characterize the phenotype, either physiologically or, you know, with some predisposition of the patient, the same intervention can work for some, as we see, and be harmful for others.
Yeah, yes, exactly. Even when we have a positive difference, a positive result, which is exceptional in our specialty, I would say, even if we have a positive result, it does not mean that all the patient can
Right.
benefit.
So you can't have a one-size-fits-all approach. You definitely
Yeah.
need to individualize because every patient is not the same. There's so much
About
heterogeneity.
DEXA, what do you think about
Yeah,
DEXA?
so
Because you published
dexamethasone,
a
so we
paper
were-
about 12 versus 6.
Right. So we all knew that we have to give Dexa, but for instance, a country like India, we were using methylmedprednisolone and very high doses. So we needed to know. So we did the COVID steroid 2 study with Professor Perner, and 6 milligram versus 12 milligram. Now statistically, there was no difference, but 12 milligram was better, and clinically there was no increased risk of complications. So clinically, perhaps as a clinician, though statistically there was no difference, I may choose to use 12 milligram of dexamethasone. And we didn't look at many factors. We didn't look at the body weight of the patients. It was a one-size-fit, whether there was a difference, whether there was a difference in the complications between, say, Scandinavia and India, between whom the studies were done. So there are many things that you can look at, but at least it gives us you some broad guidelines. For India, it was a very clear message that you can't use high dose of steroid. We had mucormycosis. We had very heavy price to pay for using very high dose of steroids. So these kind of trials, even if they are not positive trials, they give you a good message and a signal. I agree with Professor Ciccone about that. So in India, everybody started to reduce the dose of steroids that we were using following the COVID steroid 2 trial.
So we are almost at the end of this first live session. What could be your last words about the Congress, the conference, about whatever you want?
The last words, it is great that we are, you know, face-to-face having these debates, these conversations, and I really think that it's fantastic that we are back with this. We need more, and enjoy the Congress. It's going to be fun.
Sheila?
I'm really delighted to be here, and I think what's really important about meetings like this, like Professor told us, is the interaction. People come here for the interaction, to interact with experts, each other, and learn. So I think it's fantastic that ESICM could have a face-to-face meeting, and I'm really delighted that someone like me from India could come here and interact with such a diverse group of faculty and delegates. So really a great
I
honor.
do confirm that we have interacted just for this session. And Jean-Louis?
Well, since the roundtable was on leadership during the pandemic, I'd like to emphasize that we learned a lot in the organization, in the management of material and management of people during this pandemic. And there is a lot to say about how much progress we have made in these three areas. But clearly now we need to go out and tell our compatriots in our countries and inform them about the way we work in the ICU. And there are now hopefully several programs in that direction, showing to the citizens what we have done and how proud we can be of having accomplished this. And now, as Professor Kekoni said earlier, we are facing problems of burnout, of people leaving the profession, and it's primarily for nurses, but also for doctors. And so we need to do something about it. In our department today, we have 6 beds closed because we do not have enough nurses. And this has never happened before, but you know, people are tired, they want to take some holidays, etc. So we need to address this problem and try to improve the care of the critically ill. But we'll get there, I'm sure.
Yeah. Thank you very much for this very
Thank
nice
you, Professor
discussion.
Teboul.
Thank you.
Sorry that I missed the first part. You spoke about the...
Hello, everyone. So I am Professor Antoine Villard-Baron from Paris, France. I am very pleased to moderate this session with Dr. Laura Evans from Seattle, and she will speak about the Surviving Sepsis campaign, and I prepare some questions for you. The second, which is actually the third, is Dr. Azoulay from Paris about the patient's family. And the second one will join us very soon, John Lafay from Galway, about the emerging therapies in acute respiratory distress syndrome. So Laura, maybe I will start with you this interview regarding the Surviving Sepsis campaign. I was in the opening ceremony and I heard about the lecture from Jean-Louis Vincent, and I think you deserve a rebuttal because he was really not against the guidelines like the Surviving Sepsis campaign. But my first question is general. In your feeling, how to conciliate the personalized medicine we need in sepsis with the guidelines of the Surviving Sepsis guidelines?
Thank you for the opportunity. I'm happy to be here. I think Professor Vincent's purpose was to be provocative, and I think he certainly was provocative in his talk about the guidelines. But I actually fundamentally don't think that those two viewpoints are at odds with one another. I do think that there is enormous value in using structure and decision tools and providing guidance to busy clinicians out there. You know, I don't work in the emergency department, but I do go there often, and I know how busy it is, and I know how many competing factors all of my colleagues are dealing with in the emergency department, and so not providing any guidance does them a disservice. Not because they're not smart and they're not expert, but they have so many competing priorities, and to going through a detailed process to look at all the evidence, distill it down to its elements, and provide guidance to them, I think is an enormous service to patients. I think it's also really important to recognize that guidelines are exactly that. They are guidance. They're not stone tablets that never change. They are not directives of what you must do under every circumstance. And I think that's why I tried in my talk to mention a little bit about, you know, what's a strong recommendation and what's a weak recommendation. And we're offering mostly weak recommendations, to be honest. So there is a lot out there that we don't know. We're saying, here's what we think. Here's the best that we have to offer at this moment in time, and here are things for you to think about and consider. So I don't think that, and then you use your clinical judgment as a smart physician, nurse, provider, and make your best choices.
Yeah, I think it's a huge point that there is a very big gap in our knowledge. And I read very carefully the last version of the Surviving Sepsis campaign guidelines, and you very frequently suggest and not recommend. So how to have in the future, maybe for the next version of the guidelines, more convinced data, strong data. So I mean how to do better to have the adequate information to recommend for or against some therapy.
Well, that's an terribly important question, and I'm not sure I know the answers to it, other than, I think we do need more work, of course. People are, and I think the ongoing efforts of people to ask important clinical questions and design studies, both trials, but also observational, not randomized clinical trials that try to get at some of this information is incredibly important to guide that. And I'm really excited to hear Professor Azoulay's perspective on this, because I think the other perspective that we brought into the guidelines that help us prioritize what questions we need to ask was the perspective of patients and their families.
Well, I must say that the guidelines are not only providing...
In the microphone, Eli. No, very close to your mouth.
The guidelines not only provide guidance, as you said, they are also a very nice tool for training others, and a very nice a companion to be able to really help others get skills about managing sepsis. But in addition to that, as you just said, I think that the effort that he's made regularly for these guidelines makes that I'm really convinced that it helps improve outcomes at many places. So you said the emergency department, where patients are very, you know, it's a chaotic environment, and we know why. But when we look at some specific patients group, like immunocompromised patients, those who are in the wards, neutropenic, recipients of marrow transplant, and any kind of transplantation, I think that these guidelines also apply to them. And we teach these guidelines to these specialties to manage these patients differently. And I'm really convinced that it made changes.
I have one comment that Gordon Rubenfeld, who was a mentor of mine when I was in training, used to give a great talk on, I can't remember what it was, recipes and great chefs, right? And so the concept of who uses a recipe and who's a master chef.
Sure.
And he always made this point that I think was really stuck with me. And I don't know if he'll listen to this interview or not, but Gordon, something you said stuck with me, which is that the art of medicine is knowing when the guidelines don't apply. So you don't lose your ability to think critically. And you still can apply what's appropriate to that individual patient. The guidelines are just a starting point.
Okay, now, Laura, if we go through the guidelines by themselves more precisely, I mean the Surviving Sepsis Campaign guidelines, if you compare the guidelines of 2021 to the guidelines of 2016, which are the 2 or 3 main major changes that you will want to summarize?
I think the approach to the initiation of antimicrobial therapy, where we are recommending that you take into account the likelihood that you think the patient has sepsis, as well as the acuity of illness of the patient, and not recommending an hour target for antimicrobials across the board, but rather saying, if you're not as sick and I'm less certain that it's sepsis, I have some time to do a focused evaluation and really improve my certainty as to whether the patient has sepsis or not, and then changing the antimicrobial target in that subset to 3 hours. I think that's a pretty substantial change from the previous recommendations.
May I interrupt you just on that point? Just to know, because I mean this is very practical. This is what we do in our real life at the bedside to care our patients. Do we have objective data to support this kind of recommendation and approach?
Indirectly. And so that's why it's a weak recommendation. It's indirectly. So, again, there's no randomized trials of randomizing patients to 1 hour versus 3 hours to get their antimicrobials. And so we're looking predominantly at observational data and using several large cohorts of observational data to try and look at the dose response between recognition of sepsis or onset of hypotension in the case of the, Anand Kumar data from 2006. And initiation of antimicrobial therapy with the whatever time interval from how that study defined time 0 to patient outcome. And the relationship with this dose response is quite clear in observational data with patients with septic shock. It's a little bit less clear in patients with sepsis without shock, although, Ricard Ferrer's data certainly supports that, and some of the data that came from New York State's observational cohort also supports that. But that was the sort of difference between that dose-response relationship for those with shock and those without shock was responsible for that change in recommendations.
Okay, so 1 or 2 other major changes?
I think the addition of this entire section of longer-term outcomes is a big sea change in terms of that, because I think we need to, and the panel, and wasn't just my thoughts, it was everybody on the panel, really thought we need to stop looking just at what happens to these patients in the ICU and to think much more broadly about what does recovery look like for patients who survive sepsis. So I think the addition of that section is a major change. I know it's not a specific recommendation, but I think it reflects a larger movement within the Surviving Sepsis campaign to think broadly about how our patients do beyond the hospital.
And on that point, would you recommend you and you too, Ellie, to build a registry just to have more data and to follow this patient a long time after they left the ICU? We do not have so many registries in this to follow this kind of patients.
I think we do. It's a huge research gap to me, right? And whether a registry is the right approach to it, there are probably people who are far smarter than me to comment on that. But I do think we need to look at cohorts of patients who have survived this and follow them over time and I think the neurocognitive effects, the psychosocial effects of all of everything that happens during their hospital stay in the ICU is an area that is presents an amazing opportunity to further improve patient
Well,
care.
I agree. I think that I believe more into qualitative data with a very careful follow-up for 1 to 5 years after sepsis. It will bring much more information than what we can find in registries and databases. And I think it will generate hypotheses for further interventions. And these interventions need to have long-term outcomes too. And there is a lot to expect from that.
So you mean that some intervention that we could apply during the resuscitation and the ICU care could have significant impact on the long-term health status of our patients?
Yes, looking specifically to subgroups and subphenotypes of septic patients. I'm convinced that we can bring and generate hypotheses for longer-term outcomes.
Yeah, I'd love to think that something that we can do early on in their hospital stay impacts what happens 6 months later.
Okay, and maybe the last question for you, Laura, but after you may speak and comment anything you want. Just to know if you have just to give us one major action that could really save lives in the septic patients among all the recommendations in the Surviving Sepsis campaign. Which is yours?
Yeah. My personal favorite recommendation is the very simple one that states, it's a best practice statement that states that sepsis is a medical emergency and you need to begin resuscitation and treatment immediately, because I think we've done so much over the last 20 years to get that message out about how time sensitive sepsis is, and yet there's still more work to do there. So that's my favorite one.
So just may I continue a little bit, because it was one point where Jean-Louis Vincent were very critical regarding this kind of emergency, but in the Surviving Sepsis campaign, you recommend to admit the patient in the ICU within the 6 hours. We could be a little bit critical. Some people could say that this is probably a too long period. Why 6 hours?
So one is clearly recognition and treatment of sepsis doesn't begin in the ICU. In fact, the vast majority of it begins outside the ICU in the emergency department or on the acute care services. It really doesn't begin in the ICU. And so I think the statement of immediate recognition and management, by and large, is not an ICU beginning, right? The 6-hour threshold is a really interesting conversation. And you're right, there are many different perspectives in that. And ideally, I think we would say patients who qualify for admission to the ICU should be admitted there, as soon as they possibly can be. That's not a practicality in many, many places, right? And certainly in the United States and in North America, where emergency departments are a source of primary health care for a large proportion of the population, patients can stay 24, 36, 48 hours in the emergency department while awaiting a bed in an intensive care unit or awaiting a bed on an acute care floor. So part of this was to say, we're aware of all this data that suggests delayed admission to the ICU is associated with worse outcomes. Is 6 the right target? That's where we landed now. Is sooner better than 6? Probably.
Yeah, this is typically the setting where we need to target patient actions at the patient level rather than the structural level. And I agree, wherever are the patients, if they are correctly assessed and treated, it's better that they are in the emergency room than in an ICU where they are not treated appropriately. So we need to stay at the patient level.
Okay, thank you, Laura. Finally, John, join us.
Hello, Antoine. How are you?
Yeah, very well, very pleased and very happy to have you with us around this table or this corner, I don't know. John, you just reported some indication about emerging therapies, in acute respiratory distress syndrome. And I just read your paper, your narrative review that you published, I think, in Intensive Care Medicine Journal in 2020.
Yes.
And there is a huge amount of data of potential therapies. But at the end, we have nothing, let's say nothing. And it was the introduction of your lecture that right now, we do not have any treatment for ARDS. So I want to do better. This is quite the same question I asked to Laura, to translate this very interesting research, experimental research, to humans and to patients?
So I think, yes, it is, you know, you can look at it two ways, I think. You know, you can look at it and say we've failed so often that why would it be any different going forward? Or you can say, what have we learned so far that means we can do it better? And I think we have learned quite a bit that will help us to do it better going forward. We've learned, I think, that when we have a disease process that's like ARDS, which is COVID, right, where we understand the etiology, where we understand timelines, where we have less heterogeneity, we are actually very quick to do the right trials and find treatments. So we need to take some of those learnings, I think, into ARDS or non-COVID ARDS and start to run trials that are much more selective. So you need biomarkers or markers of a response to your treatment, and then you randomize that subset of patients. If you have patients who cannot respond to your treatment, let's say it's a steroid, and you don't have an inflammatory, a hyperinflammatory response, you can't benefit from having your inflammatory response depressed. You can be harmed by having your inflammatory response depressed, but you can't benefit. So we have to find ways at the bedside to identify those patients. And we have made good progress in doing that, but we're not quite there yet.
But I think this is really the main limitation of what everyone spoke about, the personalized medicine, how to better phenotype our patients. Because we have imaging, we have biomarkers, maybe we have gene identification, we have so many parameters, so many variables. So how to put everything together to have the adequate phenotype and to apply this approach. For me, this is, I like the idea of personalized medicine. This is probably something that I do every time in my unit. But how really to do? We need, let's say, artificial intelligence, big computer. How to do that?
Well, we're making very rapid progress in this regard. So we have huge amounts of data, but we are now understanding how to use that data. And I'll give you just one example. Sina Pratik and Carlin Calfee, in their latent class analysis, they've developed a machine learning model of this now. And so they've been able to show in existing databases that the machine can tell you, just from clinical characteristics, if the patient has this hyperinflammatory subphenotype versus hypoinflammatory. Now, that needs to be validated in real time at the bedside, but like, it's making progress. It's getting closer and closer to real time.
And do you think it could be very quickly available at the bedside? I mean, in the near future? Because I don't want to go back in my office just to look at in my computer what is the cluster of the phenotype of this patient, and to go back into the ICU to treat the patient. I need to have the information at the bedside.
So I think it can. I mean, if you look at the computing power that's available in the average ICU at this point, and the power of the information systems, we're not that far away. Now, it's not been shown yet, but it is getting there. So I think the answer is within a few years we will have this.
Laura, Elie, do you have any feeling, comment?
I very much hope you're right. I love your optimism of that timeline. Because it seems I do think there's been enormous progress made on all of this topic, but I do think everything takes longer than we think it should, right? In terms of, yes, we have to identify our phenotypes and ways to do this practically at the bedside, and then find the right therapeutic targets for this phenotype, and then enroll patients of that phenotype in the right timeline, in the right trial. I think we are making progress. Yeah. I don't want to put any timeline on it, though.
Well, I mean, we have, for example, like if you look at the French ARDS study, Jean-Marie Constantin study. So he phenotyped patients, phenotyped those patients at the bedside in real time to 2 different ventilatory strategies based on diffuse or focal ARDS. And so they did that already. So for physiologic markers, we can do it already. It's not perfect. but we can do it.
Eli?
I would say that I disagree with the fact that we didn't make any advance over the last 2 decades. Not only we are able to recognize, to avoid a lot of mistakes that we were doing, maybe not only by providing a certain level of mechanical ventilation, but also by maybe looking at some patients differently in terms of what we can expect from the ICU management and mechanical ventilation. And the last thing is the new approach that brought phenotypes and endotypes into our RDS is not yet conclusive, and I would say that we are going to benefit from this a little bit later. I think that we are too impatient. It's very likely that in the future, and you've seen how some trials have been stratified according to the clinical phenotypes of RDS. And for example, the effect of PEP or the effect of any other strategy has been addressed according to the specific phenotype. And again, I would say that a lot is still to be made before being conclusive about and being so negative about these trials.
This is your feeling, John? We need much more before translating this concept to the reality?
Well, if you look at, you know, so I agree. I mean, I don't disagree that, you know, with what Eli is saying. I mean, number one, we have made progress. Number two, like Laura says, things always take longer than you think they will. But we have shown already that we can stratify patients or identify responders and then test things in them. More for physiology now. I mean, proning was like that, right? The ProSiva trial did not persist in proning patients who didn't respond. And so, you know, we have the concept. It will take time for biology, biomarkers to be ready for prime time. That's going to take time. But it is the direction of travel.
I have another question for you, John, because initially during your first answer, you spoke about the COVID-19 RDS, and in your narrative review, you suggest that some advance that we did to treat this kind of patient could be applied in non-COVID RDS patient. But are you so sure that this is really true? Because we have huge difference between both, especially, for instance, regarding the endothelium injury or many other aspects. So are you really sure that what we discover for the COVID-19 RDS patient could be applied to the non-COVID RDS patients?
So I would think that it does give us, you know, ideas and new targets, but I think we would have to retest them in non-COVID ARDS. But it does inform our thinking, right? So, for example, you know, steroids need to be revisited. Now, I think we kind of knew that already with Jesus Villaris study in 2020, but there's clear, you know, the COVID data really informs us on 2 points. One, that there is it seems to work in the whole cohort, and number two, that there's a subgroup within COVID ARDS that's hyperinflamed and they respond better. So we do need to retest in non-COVID ARDS, but it does give us, again, ideas of how to do it best.
Okay, and maybe my last question for you, among the huge amount of emerging therapies, maybe I have an idea about your answer, but what is your favorite one? I mean, for the future, what is the one that you are convinced that could work to save patients and to treat patients?
Only one.
Yes,
only one.
Yes, by definition. If I say 2 or 3, it's too easy. So only one.
So I think we will find a patient subgroup within ARDS that responds significantly to steroids.
And this is not something that you already do?
No.
No? So in general, you do not treat your ARDS patients with steroids?
Not in the early phases. If they're in shock, that's different. If they have unresolving ARDS and I don't think and I've ruled out an infection, again, that's different. But in non-differentiated early ARDS, we would not give them steroids.
Not at the early phase, but secondary, maybe?
But later, yes. Later, if they're not responding and we have less reason to think that they are infected as a cause, then we would give them a trial of steroids.
And so when you were speaking about steroids, you were speaking about early steroid during the early phase?
Yeah, sorry, I should have been clearer about that. Yeah, so it's in the, if you look at the Jesus Villar population, they were patients with a PTEF less than 200, 24 hours after diagnosis. So it's that early phase. Yeah.
Comment maybe, Ellie, from your side, because, or Laura, Laura first.
I was going to ask you the question about, which is always the question that comes up, at least in the States right now, is for the steroid question is how much and for how long? Because I think we certainly have the guidance from Recovery and Solidarity and from the COVID specific. And then we have Anders Perner's recent data about 12 milligrams and the Villar study, of course, which is a different dosing regimen and for a longer duration. And so do you have a sense of where does your practice come down on how much and how long?
So I don't think, we don't know, right? I mean, the Villar study used 20 milligrams IV for 5 days and then 10 milligrams 5 days after that, whereas it's 6 and 12 are the doses being used in COVID. And so I mean, the data for COVID, I think, is leaning more towards 12 in terms of the secondary outcomes, right? But in our practice, we still mainly give them 6 milligrams IV. But in non-COVID, I think we just don't know. We would probably have to start with a dose closer to Villar's dose, because that's the one that has shown effect in non-COVID ARDS.
I think if we skip with the
in the microphone, Eddie.
If we keep the definition of RDS as it is, early steroids in patients with RDS outside COVID may be more harmful than with benefit, and we have many different examples.
Yeah.
For the late thing, I would not get into that because I think we are more into another clinical setting that itself should be stratified according to the CT, to who is the patient, and what are the underlying comorbid conditions. For early RDS, there is a very big example. If you compare flu and COVID-19, if you compare the SARS-CoV-1, the MERS, and the other pandemics, I think I would be very careful with making any generalization of the early steroids in patients with RDS. I would say that in my clinical practice, if we are really in the belief that the patient has an RDS, has the classic risk factors, and has a typical clinical and radiological feature, we will not be using steroids in this setting.
Yeah, and again, to clarify, I'm not suggesting for a moment that you would give steroids to everybody with early phase ARDS. What I'm saying is that I think we will find a subgroup within ARDS that will respond to steroids based on what we know from COVID-19 and so forth. And you'll buy a different set of complications then in terms of the secondary complications. But that I would be optimistic that we would find a subgroup within the ARDS group. But you're going to need biology to do that.
John, I dream about your optimism. I'm still convinced that overall, if you look at the big picture of the entire group of RDS patients, early steroids will be more harmful than provide benefit to a subgroup.
But
this
John,
is my feeling.
John, your answer about steroids, which is your favorite emerging therapy, is funny for me, because for me it's not really an emerging therapy. So I mean, you do not trust about all the potential drugs and therapies, just focusing on the endothelium, the epithelium. No, you don't trust about this approach.
So I have so if I can set conflicts of interest aside, the drugs that excite me most are the cell-based drugs, cell-based therapies. But I work in that field, so you got to be careful.
Okay, so
maybe the best emerging therapy in RDS is prevention, and COVID-19 has been very insightful in the number of drugs, at least in some immunocompromised patients, antivirals, anti-monoclonals, etc., that prevented the patient to really have an RDS. And I would say that I've been fascinated by this literature, but still we need more convincing data.
But even outside the COVID-19, we have some data, John, regarding how to prevent maybe RDS in high-risk patients, for instance, after trauma.
Yep.
Or could you comment just briefly about that?
Yes, I'm just blanking on the study now. I know I presented it. It's solnitide, right? Was it? Yeah. So I mean, there are drugs that do reduce the risk of ARDS. And so if we can get better at, and again, this is where data is important, right? Because you need to automate the identification of these patients. And then you give a drug that has a relatively low risk index with it.
And I would say, I would like to make reference to the works from Professor Jabert in Montpellier. In perioperative mechanical ventilation, there is so much to do to prevent post-op complications, including ARDS. I've been very convinced that translating every ICU advance to other settings will be very helpful. And I believe in that.
But you know that it does not seem to be so obvious, for instance, for respiratory settings.
Yes.
So we have some work to do again. So thank you, John, for this interview, but you stay with us because you could ask Ellie some questions about the patient's family communication. So Ellie, now this is the third interview of this session. So you have a world expert about patient's family and communication with family, especially to avoid or to limit grief after the family, after the patient died. And so just I want to ask you the first question, because I know that you publish a lot during this period. Did you observe really a significant difference regarding the family during the pandemic and before the pandemic? And if so, what are your explanation and the reason for?
Well, first, we have Laura Evans, and Laura Evans is from Seattle. And I could not start without saying that I have a very, very close friend and mentor working in Seattle. You know, and having worked with him changed really my perspective of the topic. So let me start by the beginning. I think that we have now the evidence that observational data not only reported that there were communication gaps as well as some family issues. These family issues, I would say, artificially have been, you know, globalized and took the name of family post-intensive care syndrome. I think it's not really appropriate, and I share with Randy Curtis, who is really the leader in the field and a very, very important person. I think that we should work more on defining this, but still there. And the other thing, and we have been convinced over the last years that words can play as drugs, and communicating better can provide different outcomes. That being said, before COVID-19, one of the major observational, I would say, mnemonic driven by a very, very large qualitative research from Randy Curtis built a mnemonic. And the funny thing is that we in France could have performed a randomized control trial using the mnemonic, but our trial would have been negative in the US because at the time we did the trial, this was already in Euro standard of care. So this is the interesting thing.
So we have the same issue than when we want to look at, for instance, the early goal-directed therapy in sepsis.
Not anymore, because now, 20 years later, we are in Seattle and in France doing the same trial. We have finished before you. But still, when Randy Curtis came to Paris for a year, and he designed with Nancy Kentish-Barnes, and the same trial is being performed in the two sides of the globe. And I think that this is a major advance. Let me go back now to your question. Yes, the answer is yes. COVID-19 has been disruptive for family members. And in a study where we had a control group, which is, I must say, a suboptimal control group, because obviously patients without COVID were hospitalized at the time where our hospital were surging. So I would say I would not be so, conclusive about the control group. But we had patients with flu and communicable pneumonia, and there is no doubt COVID-19 imposed to family members more burden. More burden in terms of anxiety, depression, post-traumatic stress disorders, and unfortunately also complicated grief in family members who lost their loved one in the ICU. You said why? So we are now doing what we call a mediation analysis, that is a statistical trick that really ascribe an effect to a variable. It's not so easy, but let's say we play with that. But there are three things that are really provided by the qualitative data. There is one very nice study published in JAMA Internal Medicine by Randy and his group, and our paper in JAMA with the French study with the control groups. I would say that there are three things. One is visitation policies. They have been very restricted. They have been very limited, and obviously we were not able to care for patients and family members as we usually do.
Just on that point, Eli, I have to say that in our group, they were asking us to limit or to avoid any family visit. And I know that in your ICU, but in my also, this is something that we did not do.
Yeah, we transgressed the recommendation to avoid having
the
family members. We were
recommendation.
24/7 even during the time of COVID. Obviously, when family members were themselves sick, we were asking them not to come. The second thing is the feeling of isolation, and this is coming from a huge amount of data in the literature. Family members felt very isolated, either in the ICU when they were coming, or at home, or in other places. And three is infodemia. Infodemia has been very toxic. The power of the newspapers, the television, the social media has imposed to family members another source of stress. And I would be very interested to know how it was in the US and at your place, John, because it has been, at least for us, and we know that, it has been a huge source of toxicity, and this has translated into poor outcomes in family members.
Laura?
Well, first to your comment, the rampant misinformation and disinformation have been immensely stressful for families and generated, I think, a lot of conflict with the healthcare teams as well, right? From that, I'm interested, just as one follow-up question to what you were talking about, is we heard earlier, which I think Mauricio was talking about, the rapid escalation in burnout amongst ICU staff, particularly ICU nurses probably, but across the board with the ICU staff. And I'm wondering how you may think that would impact our ability to communicate with patients and their families.
Well, the truth is that one of the main sources of, I would say, burden on healthcare providers was family absence, the fear of contaminating, of infecting family members, sometimes the inability to rest because it was really a physical burden. And the last thing was about, the regress of providing suboptimal care, having, hasty end-of-life decisions, etc., etc. We have been in surge, so we have faced a very complex situation. That being said, we didn't move really from observation to interventions. And we need to do that, so we are now working on that, but of course it will be after COVID, hopefully. And what we can do is at least work on ICU organization, working on the environment, the ethical climate, and also making the ICU safer for healthcare providers, and we can make it.
I do wonder about the sort of structural components that you're alluding to in terms of, do ICUs that have staff who are less burned out do a better job?
Oh,
and I'm
course.
sure they do,
Yeah.
but is that something that we need to measure when we're thinking about interventions?
But there is a paper published in JAMA something like 18 years ago, showing very clearly that if you are adding one patient to every nurse, you increase the burnout in nurse, and you decrease what you can expect in best outcomes at the patient level. And we know it was in the New York, in the New York Times yesterday. There is a huge paper now that is translating how much the surge and how much the nurse-to-patient ratio can affect clinical outcomes. I think there is no doubt. The question now is, what can we do? Should we treat less patients to provide best outcomes, or should we treat more patients and alter a little bit the outcomes, so we are opening a new door?
John, a short question for you, but you may comment also on what Eli and Laura said. Just to know, in your unit, did you allow family visiting, especially during the first wave, or did you stop any visit?
So the hospital policy was to stop visiting. So what we did was we adapted that because there was actually a lot of healthcare concern in the ICU about the risk of them getting COVID from families visiting.
Of course.
In the first phase. And that did settle down over time. But what we did as a compromise was for patients, if they were clearly not doing well, we did allow a visit. But it was it was tricky, and we just had to try and do it on a case-by-case basis.
So we all have the same experience.
Yeah, yeah.
That's what we did as well.
Yeah. And
yes, you
I was gonna say,
wanted
one
to
of the
comment.
things-
Yeah.
One of the things we used so we obviously were trying to learn, like, you know, COVID kind of came in a wave across Europe, and as Ireland is on the west, we were a little later than say France or Italy especially. And our local companies, we have a lot of medtech and IT around Galway and Ireland, and they came in advance and asked us what we needed. And one of the things we asked for were good communication tools. So they actually brought us teleconferencing equipment for the COVID bedsides. So the COVID patients every day got to talk to their families.
Yeah, this is something that we tried to apply, but it was not so easy. But we did it. Eli, maybe one important question for you. I know that you have money for thinking and better for building a communication system.
Yes.
From a regular basis to improve family communication and so to decrease the prolonged grief in this family.
But for Laura, money is money. Money is a painter, but money, you refer about money. Yes.
Could you explain briefly?
Yeah, we applied actually to a national grant where we are attracting the industry and industrial companies to provide tools and digital tools mostly, but not only, to improve the family experience. So this is a global project that it will be performed in our study group in France. And of course, we have other connections, and we have discussed this a lot with Randy Curtis and with other specialists all over the world. So with Judy Nelson, with Giovanni Mistraletti, so with many different people. So what is it? It's actually how we can understand the actual risk factor for post-traumatic stress disorder. But for the first time, we are going to do sampling in family members and to identify molecular signatures of PTSD. We will include these genetic variables into a clinical algorithm that will be offered in a platform to detect those family members at high risk of PTSD and offer an online service by psychologists, psychiatrists, and ICU specialists, mostly nurses. So this is one of the aspects. The other aspect is offering tools that are virtual reality, videos, cartoons, and other things that can help family members understand, because we know that 50% of family members don't have an appropriate understanding of what is ongoing in the ICU. So we want to improve their experience to empower them and make them safe surrogate decision makers. So this is the project.
It's a huge.
That's a
huge
pretty
very cool.
And you said I'm an optimist, Eli. Yeah, yeah.
He is optimistic. Yeah. Maybe another question, very naive question, just to cross with sepsis and RDS. In your expertise, do you think that the cause of death or the cause of admission in the ICU could act on the family issue? It's a very naive question, maybe not.
It's not a naive question. There are three things in the literature. One is when family members see the patient having difficulties breathing, when the patient is intubated at the time of death, so you know that this is an experimental model for complicated grief. The second thing is brain death. So brain death, we are failing to really incorporate family members in the ICU. And there is a very nice and small randomized control trial performed in the US when you assess clinical examination, when you assess the patient to know whether he or she is in brain death, and you invite family members to look at you and to witness every elements of the clinical examination, you increase understanding in family members, you don't increase PTSD, and you decrease the burden after the loss. So I think that this is a very important thing. And the last thing is about advance directives. If family members are convinced that the goals of care are aligned with patients' values, so this is much healing for them, and I think that we need to understand better and go towards this in a close future.
Okay. Thanks. Laura, John, do you have other comments or questions? Or do we conclude the interview now?
Yeah.
I'm ready to conclude, but thank you. This has been fun.
Yeah, it was nice. Thank you.
Nice.
Yeah,
John, thank you, Laura. Thank you, Eli, for this very nice discussion.
Thank you, Antoine.
And enjoy your congress.
You too.
Ciao.
Bye-bye.
Bye.